integration and financing. Before we start, kindly note the following. We will have 2 sessions, today and tomorrow. Each session will be for 1 hour, 30 minutes. We will have time for presentation as well as questions and answers. You are requested to mute your mic during the webinar. If you have a question, kindly write it on the Q&A box. The session moderator will raise it during the Q&A part. The sessions will be in 4 African Union working languages: English, French, Arabic, and Portuguese. Click on the interpretation icon and select which language you are comfortable with to follow the webinar. In the chat box, you will see community health documents that contain more information on strengthening and financing community health workers program. You are encouraged to read them soon after the webinar. Once again, we thank you for joining us to advance the voice of this very important health workforce during the pandemic period. So, ladies and gentlemen, it is my honor to introduce the Director of Africa CDC to give his welcome address, and then we'll follow that by Her Excellency President Ellen Johnson Sirleaf to give her speech for 10 minutes. Over to the Director.
Thank you, Mohammed. Let me first of all thank you for the hard work, the commitment, and the diligence in which you have been driving this agenda on community healthcare workers, and especially recognizing that it is truly the interface between health security and universal health coverage. Her Excellency, President Ellen Johnson Sirleaf, I lack words of appreciation to recognize your devotion and always the commitment in making sure that this important agenda is carried forward. Your Excellency, Ambassador Louis Brown, former representative of the Republic of Liberia to the United Nations, I recognize your presence on this platform. Excellencies and representatives from the African Union member states, you are welcome to this forum. Ladies and gentlemen, it is my great pleasure to welcome you to this critical webinar series on community health systems integration and financing, part of the work on surging frontline health workers for pandemic preparedness, response, and health systems resilience. The overall goal of the discussion over the next 2 days is to discuss implementation of the partnerships to accelerate COVID-19 testing in Africa, in Africa. We recognize that it is extremely important that we continue to maintain this agenda. That is the need to expand testing, and which is driven by the community healthcare workers. Let me bring on my camera since Her Excellency is there. So the goal of this will be threefold. One is to share the impact and opportunities to improve the PACT. PACT is a partnership for COVID accelerated, of course. Second, to showcase the trump and the challenges of compensating and integrating PACT into existing community and primary healthcare systems in the country. Share the key opportunities and challenges in scaling high-performing and integrated community health systems while illustrating the role of financing and political, operational, and programmatic sustainability in these programs. At this point, ladies and gentlemen, Excellency, let me just say this, that the community healthcare workers program and the frontline will be extremely important in the coming months and if not years in our ability to fight COVID. Let us be very clear. As we speak as a continent, 31 countries are going through a third wave, and the access to vaccines are just beginning to arrive. It will take us to the end of next year to vaccinate the appropriate level of people that will create herd immunity. And we also know that there are issues of variants that are all challenging all of us. We truly don't know. I describe the future of this pandemic as uncertain and unpredictable. And I say that justly because of this, what we are seeing. I say this to remind all of us that testing will continue to be the cornerstone for us to fight this pandemic. And in the coming weeks, the African CDC will be driving a campaign where we call it enhanced surveillance, where we believe that if we roll out rapid tests, that is the antigen test, at a community level extensively, we can pick out those hotspots before they become wildfires. That is the only way we are going to buy time until we get the vaccines available there. So we cannot leave with this pattern of a third wave, then a fourth wave, then the fifth wave. It will not work for us. So we really need to be sure that we continue to expand testing to bring down the level of the new cases all the time. And the only way to do that is to do that, the testing at the community level. And community healthcare workers will continue to play a very important role in this aspect. I'm therefore delighted to welcome my co-host for this webinar series, Her Excellency President Ellie Johnson Sirleaf, to take us through her presentation to introduce our discussion today. Excellency, you are welcome. I think Her Excellency is muted.
Thank you, Dr. Kengason, for your kind words. And thank you so much for the quality of your leadership at the Africa Center for Disease Control. I'm just pleased that the Ellen Johnson Sirleaf Center for Women in Development had an opportunity to partner with you for this webinar, a partnership that is intended to enable the realization of the commitments of our continental leaders through a decision of the African Union for the increase of community health workers. In the decision to increase the number of community health workers by 2 million, the African Union and the Africa CDC have committed to a long-term vision to improve public health delivery in our continent. The COVID-19 pandemic continues to remind us that when it comes to the prevention, detection, response, and mitigation of health threats, a community-based approach is critical, more sustainable, and that which can guarantee results. Today, however, despite the vision in leadership and political commitment, Africa faces an estimated $2 billion United States dollars funding gap in building more resilient primary health systems. This amount could be utilized to prioritize frontline health workers during the vaccination rollouts, ensure health workers are protected with PPEs, as well as provide community health workers with digital training equipment and the supervision they will need to do their work, including in the most difficult to reach places. I know that a protected and integrated health worker offers benefits to their respective countries that go well beyond health. These benefits are in economic and social sectors. The benefits can be seen in a continuation of essential health services from community health workers to maintain speedy reaction and coverage of community delivered response, and can, during this pandemic period, job creators, employment of community levels will contribute to the reactivation of local and national economies. A fourth non-benefit in the advancement is the advancement of gender equity. I'm sure we all know that women make up some 70% or more of the global health workforce and contribute with their underpaid and unpaid work an estimated $3 trillion United States dollars to our gross world product. Providing for the compensation of community health workers in one way to ensure that the labors of these women are both properly rewarded and do not go unnoticed. When women get paid, children go to school, the welfare of the community are relatively improved. In spite of this, we are confronted with the present reality that the current financing architecture is neither effective nor adequate to scale up and ensure community health workers are robust. As a former president who led the nation to battle against a pandemic, I know we need increased accelerated investment that are coordinated around country visions. We need technical support for institutionalizing community health systems, including increasing domestic fiscal space. And we need multi-country approaches that will accelerate the learning curves. National health authorities and governments need to have timely and effective responses to outbreaks, as well as disease prevention and surveillance. This cannot happen with the current level of investment in public health. Simply put, investments must be reinvigorated, particularly in building and strengthening community health systems. And these cannot be the sole burdens of individual countries and governments to bear these. The required levels of reinvigorated investment that are needed and must become a global responsibility to equal, because none of us is safe with weakened national health systems. This is why discussions on public health at this one must also include country voices and local experts so as to properly shape the financing and political prioritization, guaranteeing that international commitments and policies are matched with national realities. This webinar series seeks to foster such important coming together, pulling from across the experiences of countries and enabling a chance to share and learn from each other about the important role of community health workers in the ongoing pandemic response. It is also an opportunity to explore how to further integrate and scale up the important commitments of community health workers to the overall provision of essential health services. In this regard, let me commend the African Union and the CDC for the PACT initiative, which we will be hearing about in the coming statements. Now is the time for the world to think boldly. Now is the time to innovate and collaborate. It's a time to advocate for what is possible, to be able to address long-standing injustices and inequalities. It's time to address the current and future health challenges. We should not again face another pandemic. We must time to realize our national and international commitments to make our countries and our world safer and healthier. It is not about talking. It is about doing. And the community health workers have led the way. I thank you for the opportunity to participate. Look forward to a very active discussion, with particular thanks to Dr. John Kengasong for what he is doing to bring the African health workers to the forefront and to recognize them for what they have done. Thank you so much.
Director, you are muted.
Yeah, so you think that by reminding others that they are muted, that you also know is that you should unmute yourself. I was thanking Her Excellency for her really wonderful comments and really pointed comments with respect to what we are trying to achieve here collectively. I think, and her speech highlighted that the foundation of our health system is the community healthcare workers, and I believe that in that very, very seriously. So at this point, Mohammed, I'll turn it over to you to run us through the rest of the program.
Thank you, Your Excellency. Thank you, Director. Let me quote Her Excellency, it is not about talking, it is about doing. I think the continent is blessed that during this pandemic, we have great leaders like Her Excellency and the Director of Africa CDC who believe in doing and not just talking, and doing and showing action. Thank you to both of you for joining us. We, as stated earlier, Africa CDC set up the PACT initiative, and part of that PACT initiative, we set up a community health technical working group. We want to hear more about what Africa CDC has been doing in that regard. Let me hand over to my co-chair for the moderator for this session, Dr. Diana. Dr. Diana, over to you to take us through to the next presentation. Thank you.
Thank you very much, Dr. Mohammed. And what a pleasure hearing the great remarks by Her Excellency President Salif and Dr. Kengasong that lay such a strong foundation for our next session that Dr. Mohammed has alluded to. As you all are aware, the African Union, through Africa CDC, launched the PACT initiative, which is the Partnership to Accelerate COVID-19 Testing. Through this initiative, Africa CDC has been able to deploy about 17,000 community health workers that have supported in the COVID-19 response activities. And so this particular session will really provide the overview of the PACT initiative, its progress, and impact on the overall response. At Living Goods, we know how important community health workers are. And we have seen that community health workers reach the last mile. And we have also seen the impact that community health workers can have on the overall ecosystem. In Uganda, we just experienced the surge, and community health workers have been doing contact tracing, information education, communication, and vaccines. And so we're very happy that the leadership at African Union is leading, and African member states acknowledge the role of community health workers through the PACT initiative. We're so pleased that Africa CDC is leading this work together with the member states. And we know that Dr. Heralinda, one of the amazing leaders at Africa CDC, continues to champion this work with the great support of Dr. Mohammed and in the leadership of Dr. Kengasong. Dr. Heralinda Temba is a medical epidemiologist at the Africa CDC, and she's the co-lead of the PACT CHW initiative. Without further ado, allow me to invite Dr. Heralinda to take us through the PACT Community Health Worker Initiative that she currently coordinates at Africa CDC. Dr. Heralinda, over to you.
Thank you so much, Diana, for the introduction. Your Excellency and dear participants, so I'll be taking you through the PACT CHW initiative overview. Can I have the next slide, please? So I believe most of you have heard about the PACT initiative, and the PACT stands for Partnership for Accelerated COVID-19 Testing. So under this initiative, there are three main components. The first one is to test, to diagnose the cases, the trace component to identify cases and their contacts, and the treat component to provide the supportive care in asymptomatic cases. And it is under the second component, that is the trace component, where we have the CHWs. And the target for Africa CDC is to support around 100,000 community health workers across the AU member states to support with the COVID-19 response. And this is in line with the AU Assembly decision of supporting around 2 million community health workers across the continent. Next slide, please. So as I mentioned earlier, the target is to deploy around 100,000 community health workers sustainably, specifically for the COVID-19 response by December 2021. But beyond December 2021, we have another target of scaling up the capacity building support to support over 1 million community health workers to address future public health needs. How we are going to do that is by engaging AU member states, partners, and the CHW stakeholders in different ways throughout the implementation. And the support that we provide under this partnership is advocacy for political support and buy-in by the member states, technical and financial support to cover for the training, supplies, tools, and also to pay for the allowances of the CHWs who are deployed. And the activities which have been implemented by these CHWs, it includes surveillance activities such as contact tracing, active case search, risk communication and community engagement activities, and also to facilitate referrals. And now with the availability of the vaccines, we are engaging the community health workers in the vaccine rollout as well. Next slide, please. So to date, we have made some progress, and we have been able to support the deployment of over 18,000 community health workers across the 26 AU member states. And these CHWs were able to visit more than 2.5 million households for contact tracing, active case search, and risk communication activities. Also, the deployed teams were able to identify over 1.6 million contacts. And out of those contacts who made this suspect case definition, then they were referred for testing, and that accounts for 78%. Also, the deployed CHWs were able to conduct over 3 million risk communication and community engagement sessions. And the structures that have enabled us to do all this work, it includes the leadership of the AU and the Africa CDC, the partners support, and also the very strong technical working group, which is comprised of a representative from the member states, our implementing partners, and the technical advisors. Also, we are in the process of establishing a community health services unit that will be under the Division of Diseases Control and Prevention led by Dr. Mohammed. Also, we have been able to conduct some surveys to get to understand the current situation when it comes to CHW implementation. And also, we did visit some countries and provide some supportive supervision visits. Next slide. So throughout the implementation, we were able to learn some lessons. And some of them are opportunities and some were the challenges. So in terms of the opportunities, we learned that with effective training and support provided to the CHWs, then they are critical manpower for public health emergencies response and also for the continuum of essential health services. We were also able to learn of the progress that has been made on the establishment of the national CHW programs, which are government-led. And that made possible for us to make use of both the new and existing CHWs during the PACT CHW implementation. We were also able to witness a number of available community health programs, guiding documents and tools developed by different partners and the countries themselves. We were also able to see the available partners, donors, and civil society organizations and the networks to support community health programs across the continent. And especially, we were so moved by the committed human resource that is ready to be capacitated and serve their communities. And these are the CHWs who were already on ground to do the work. Next slide. So despite the opportunities that we saw, also there are some challenges. Still, in a number of countries, there is an inadequate political and financial support to community health system, hence sustainability issues. And tomorrow we are going to hear from Ethiopia on how they manage to sustain their community health program. Also, we learned of the inadequate coordination, presence of vertical programs, and fragmentation that exists that led to ineffective use of available limited resources. Also, we saw the disintegrated approach, hence lack of recognition of the available CHWs, what they can offer. Then that led to inadequate compensation, that led to inadequate use of this available human resource for health. Also, there is an incomplete information on existing CHW resources. If you go to some of the countries now and just ask, how many CHWs do you have? They don't even have that information. And that makes it difficult to even plan on the use of these available resources. Also, another challenge is an inadequate use of available resources, being it the different documents which are already there, the databases for these human resource for health, they are not adequately used so far. The other challenge that we saw is a non-standardized CHW capacity building and support mechanisms. Because if you go to the countries, you will see a number of partners who are leading these CHW programs in the countries. And each of these partners will be having their own tools, their own training manuals, and so forth. Next slide, please. So we came up with a few recommendations. And the first one is to advocate in order to accelerate the political momentum and financial support for community health system strengthening. Also, for the countries and also at Africa CDC to leverage on partnership and coordinated efforts, both at the continental, regional level, and at the country level. Also, to advocate for increased domestic and external investment in community health systems. For the countries to map out existing CHW resources. Also, for us to be evolving as the new innovations are coming. Up to now, many countries are still using paper-based approach in the training, data collection, and everything, while there are a number of digital tools out there. And also, another recommendation is to build capacity of already existing CHWs so that they can fit into the requirements of the countries and qualify to be among the CHW for use in the future pandemic, and also to sustain the pact gains. Next slide. So these are the different ways that as Africa CDC, we are going to support the countries in terms of advocating for the political support, building a conducive policy environment, support the specific pathways for sustainable, also to promote for the uptake and adherence on the available CHW tools, and also to advocate for the integration. CHW not linked to the overall national system. And the last slide, this is the last slide, please. Okay. So this is just a quote from our director, Dr. John Nkengasong, the Africa CDC director, emphasizing on the critical role of CHWs. Thank you so much.
Thank you very much, Dr. Heralinda, for such an insightful presentation, but also very detailed for us to really see the progress that the PACT initiative has made in the member states on the continent. Having heard from Dr. Heralinda, it's now time to have a deep dive in from key representatives of countries, but at the same time hear from two amazing community health workers. And to start with, allow me to do a brief introduction of all the speakers that we will have. One is Dr. Remy, who is representing the Arab Republic of Egypt. And in his presentation, he will highlight for us how they've been able to integrate community health worker initiatives in their work. The second presenter this afternoon is from Cameroon. Dr. Chanceline Bilongo Ndongo was recently appointed as the Epidemiological Surveillance Unit Chief at the Department of Control of Diseases at the Ministry of Public Health, where she's been working since 2016. She contributes to the coordination of epidemiological surveillance and preparation of the response. The third panelist for us is Dr. George Upentho, who is the Commissioner at the Department of Community Health in Uganda. He serves on the COVID-19 task force, and in the past he has worked with the Ministry of Health. And right after those three speakers, we will then have two community health workers plug in and share. It is now my singular honor to welcome Dr. Rami to take us through the presentation for Egypt. Dr. Rami, you're welcome.
Hello, everyone. It's such a pleasure being with you today to discuss a very critical that affects the entire world. This pandemic has changed on all levels, health systems. It gives us a clear picture. I am Rami Jalal, head of the technical office of Minister Assistant to Public Health Project and Initiatives. we will sharing the role of the community health workers in Egypt. The national program of rural midwives, around 14,000 community health workers, is one of the great accomplishment of Egyptian women in rural cities with the population and the family planning sector of the Ministry of Health and Population. This program established in 1996 to help reduce the rising fertility in the country by providing family planning services and improving demographic characteristics and health behaviors, and to reach the target group in their rural locations. It aims to be the country arm of an integrated strategy for family health that combines family planning, reproductive system, reproductive health, and maternal and child health. One year later, we started the BACT initiatives in Egypt. We start with the one governorate, rural governorate. It's Kalubea governorate. We start with 200 community health workers. As you see in this table, the household visits around more than 68,000, and the contact divide around 4,500, and the contact being monitored around 4,000. Contact who completed the 14 days monitoring period, 3,300 people. Contact who are lost to small number around more than 300. Contact who developed COVID-19 signs and symptoms, 600. Contact who meet the COVID-19 standard case, 302. Number of the COVID-19 suspect case identified through these initiatives, active case search 1,094, and the detection point 1,826, and self-reporting 101. During the BACT initiatives in Kalubea governorate, we using mosques and churches to deliver awareness message by the religious leaders. Collaboration with the private laboratories and the private pharmacies, raising their awareness and encouraging them to report the cases suspected of the COVID-19. Also training volunteers to help in the needs of those who are isolated. Teams of 100 million health lives initiatives to support women health were encouraging beneficiaries to take all preventive measures and to self-reported any respiratory symptoms. Also, we have 100 million health life initiatives for early detection of malnutrition diseases among school children. We're also helping in raising awareness during their routine activities. Community health workers are committed to a minimum of 8 house visits per day, raising awareness about COVID-19 virus and how to prevent it. Also, they were responsible for 688 with 37.5% out of 1,869 reported cases from active search or through contact tracing. They also helped the public health professionals in filling out cases investigations form. Out of 1,830 cases, they conducted case investigation of 688 cases that were reported by the surveillance team in the country. By discovering 688 cases and encouraging cases to self-reporting, case reporting mechanism for COVID-19 surveillance activities were obviously improved. Community health workers were raising the awareness during the family survey and the family planning awareness activities. They also shared in seminars inside mosques and churches. Launched the national campaigns for vaccination along exhibitional campaigns, especially against measles and polio for all residents, both Egyptian and non-Egyptians that are living in Egypt. Egypt has been providing health care services to the most vulnerable groups in prisons and mental health clinics, addiction treatment centers, as well as continuing to provide service to the elderly through launching early detection initiatives and follow up on chronic disease. Also, action plan to protect citizens from increase the infection rate from chronic disease as a result of challenge affecting the provision of primary health care services in light of the ongoing pandemic. Importance of implementation national plans to achieve the sustainable development goals, particularly achieving universal health coverage with Egypt has accelerating the implementation, identifying work on presidential public health initiatives which result in the elimination of viral hepatitis and reduction of non-communicable disease, ending waiting list for micro and fine surgeries.
Thank you so much.
We have some challenge.
Thank you so much, Dr. Rami. Just wanted to request that you please wind up on the challenges in the interest of time. Thank you.
Some families were resistant in telling some personal information like names or occupational of contact. We suggest not to collect names in official document. Non-compliance with the health quarantine of some cases who are living alone. So volunteers were asked to help their isolated person. Some families believe that the COVID-19 pandemic is over. Thank you.
Thank you so much, Dr. Rami, for that very comprehensive presentation around the Community Health Worker Program in Egypt. I know that there are a couple of questions that our participants might be having. Please feel free to put those in our chat. At the same time, we have a team of dedicated, amazing people that will respond to them, but also we'll have the Q&A session where our panelists will be able to answer some of those as well. And so it is now time for me to welcome Dr. Chanceline, who is really going to speak about the Community Health Worker Program in Cameroon and focusing on their integration approach. Dr. Chanceline, you're very welcome.
Thank you, Dr. Diana, for giving me the floor. Good afternoon, everyone. I think you can hear me. It's my pleasure and also an honor to be part of this panel. So I will share with you the experience of Cameroon. As mentioned, my name is Chanceline Bilungandongo. I am from the Department for the Control of Disease, Epidemics and Pandemics. Slide, please. I will continue in French. Donc, il faut dire que conformément aux exigences du règlement sanitaire international, la détection précoce et la notification immédiate des maladies à potentiel épidémique et autres événements de santé publique sont essentiels à une investigation rapide et une intervention également efficace. C'est dans ce cadre que le Cameroun a adopté la stratégie de la surveillance intégrée de la maladie et de la réponse. Et la riposte. Il faut dire que de nombreux événements de santé publique ne sont pas toujours pris en compte par le système de surveillance usuel qu'on connaît et tous ces événements ont pour base la communauté, d'où donc l'importance de la mise sur pied d'une surveillance à base communautaire efficace afin de concourir à l'alerte précoce et la riposte. Il faut dire également que la pandémie COVID a révélé de nombreuses insuffisances et avec la propagation du virus dans les communautés, l'importance des agents de santé communautaire s'est fait ressentir parce qu'il a fallu qu'ils soient davantage impliqués afin de contribuer non seulement à cette détection précoce-là, mais également de sensibiliser les populations vis-à-vis de cette nouvelle maladie qui au départ entraînait beaucoup plus de peur. Diapositive, s'il vous plaît. Au Cameroun, il y a de nombreux projets de surveillance à base communautaire qui sont mis en œuvre. Slide, please. Il y a de nombreux projets qui sont mis en œuvre, comme l'a mentionné Elinda tout à l'heure. Et nous souffrons vraiment de cette multitude de projets-là et également des problèmes de coordination. Donc, le projet Pacte est arrivé et il a trouvé qu'il existait déjà la surveillance fondée sur les événements qui se fait dans des régions sous forme pilote. Actuellement, 5 régions sur les 10 régions que compte le Cameroun sont impliquées et ça contribue également à la notification de tous les événements de santé publique pour lesquels une liste a été faite, ça existe, et également des événements inhabituels que les populations peuvent rencontrer. Nous avons le projet CP3, Community Epidemic and Pandemic Preparedness Program, qui est dirigé par la Fédération internationale de la Croix-Rouge et qui contribue également à améliorer les capacités de détection des communautés vis-à-vis des urgences de santé publique. Le projet Early Warning and Response System de l'OMS a également été mis en place et ceci dans les zones notamment d'insécurité. Le Cameroun a 2 régions en insécurité actuellement, la région du nord-ouest et du sud-ouest et là-bas des données sont également collectées à travers une plateforme. Et enfin, nous avons également le projet de surveillance de la mortalité maternelle mis en place par CDC pays. Et je vais encore le redire, la multitude de ces projets qui parfois sont verticaux et parfois également apportent de nombreux outils, parfois utilisent les mêmes acteurs du système, les mêmes agents de santé communautaire qui à la fin se retrouvent surchargés. Mais ce qui est bien à savoir, c'est que quels que soient ces programmes, ils utilisent toujours les principes de la surveillance à base communautaire que sont la détection, la notification, le triage, la vérification. Et enfin, l'évaluation des risques qui se fait au niveau du district de santé, même comme nous avons relevé des faiblesses, notamment dans le cadre du renforcement des capacités de ces personnes, des acteurs, notamment les acteurs des districts. Maintenant, le projet Pacte, pour parler spécifiquement, slide please, le projet Pacte avait pour objectif d'impliquer la communauté dans les activités de surveillance épidémiologique. Et à cet effet, 940 acteurs ont été mobilisés, notamment 720 agents de santé communautaire qui avaient des superviseurs de proximité, autour de 200 superviseurs de proximité et 10 superviseurs régionaux qui avaient également été impliqués. Il s'agissait aussi d'identifier et de rompre les chaînes de transmission de la COVID-19 d'accroître la rapidité d'identification des cas de la COVID-19. À cet effet, 556 068 visites à domicile ont été effectuées par ces agents de santé et cela a permis d'identifier autour de 192 000 cas suspects de COVID-19 qui ont été référés et pris en charge par le système de santé. Enfin, ensuite, il fallait renforcer la recherche active des cas. Il fallait gérer et sélectionner les alertes, améliorer la réponse en temps réel. Dans la recherche active des cas, on retrouvait également les activités de suivi de contact pour les cas confirmés qui avaient été identifiés. Et à cet effet, 25 379 contacts ont été identifiés et suivi également. L'une des activités importantes et non des moindres, c'est la sensibilisation des communautés. Les agents de santé qui ont été déployés sur le terrain avaient un carnet de route, avaient des indicateurs de performance à atteindre en termes de visites à effectuer, en termes de sensibilisation, de séances de sensibilisation à effectuer, que ce soit dans les communautés, dans les marchés ou bien les zones à grande fréquentation. Maintenant, dans la mise en œuvre de ce projet, nous avons appris beaucoup de leçons afin d'améliorer. Slide, please. La première leçon, slide, please. La première leçon apprise est qu'il est important de choisir des bonnes personnes comme agents de santé communautaire. Ces personnes doivent être volontaires, elles doivent être disponibles. Et lorsqu'elles sont choisies, il faut également les former. Actuellement, le Cameroun tend à avoir des agents de santé polyvalents, c'est-à-dire que ce n'est pas un agent de santé spécifique à une seule maladie, mais pour une intégration des ressources, une mutualisation des ressources, ces agents de santé deviennent finalement des experts un peu sur tout. Ils sont capables de vous notifier non seulement les cas de COVID, mais tout ce qui est poliomyélite, rougeole, choléra. Et ceci permet toujours la détection précoce. D'où l'importance de pouvoir bien les former et leur donner les éléments nécessaires pour le faire. En dehors de cela, comme autre leçon apprise, c'est l'importance d'utiliser des outils de collecte de données harmonisés afin de diminuer la charge de travail de ces agents de santé, mais également d'avoir des indicateurs de suivi et évaluation afin d'analyser les performances et voir quels sont les leviers sur lesquels il faut appuyer pour obtenir de meilleures performances. Les agents de santé communautaire sont déployés sur le terrain, mais ils ont également besoin d'un appui.
They need support. That's why it's important to have supervisors, close supervisors, so as to improve their skills and to ensure that they can solve problems that they encounter on the ground. Now, one of the other lesson learned is that today, the officials that we have don't have all the tools to carry out their work well, especially in the risk assessment. When cases are notified to these health workers, there's need to ensure that they have the capacity to tackle these cases. And this is one of the weaknesses which we have, lack of tools. Now, the other thing is that we have a coordination team at the district level, but at the regional and central level. And these make sure that all that is done according to the standards that have been laid down. But this raises challenges. There are many projects which we need to coordinate. Next slide. Now, the main challenges which we have faced in the implementation of these projects include the lack of data. COVID-19 is something that has to be notified immediately, and the systems had been put in place to collect data, including new technologies through applications, so that notification is instant. But it is not always the case. Our health workers face a number of public health problems in the communities where they are working, and they are overwhelmed. Now, these health workers that we have sent to the field do not have the equipment for individual protection. Sometimes there are many, and they go to different districts, and sometimes the resources are not enough. They're limited. So there is lack of funding, and of course, this is seen everywhere at all levels, and the low implication of some actors who haven't understood the importance of this community-based surveillance, and sometimes they cannot be able to survey these epidemics. Now, then in this at this community level, we have certain tools which are not known by all the actors, and that's why it's important we ensure that that community surveillance is reinforced. There should be integration of the different projects which are implemented. And this is not there, and sometimes resources are wasted, and these resources could have been saved if we were well coordinated. Next slide. Now, what we can recommend as a way forward is that, as you can see on this table, we did an assessment after the implementation of the project. This is an assessment of a community action involving all the actors who participated in this project. They were all involved in this assessment. There was Red Cross, CDC, and so on. Now, the first recommendation is that we must have a total mapping of the different strategies which exist so that we can have a better visibility of the partners who implement the event-based surveillance and ensure coordination and coherence in the implementation of these activities. It's important to make sure that we continue with these surveillance, community-based surveillance activities. This is a 3-month project, and once this stops, so sometimes the health workers may get discouraged, but we need to implement all the results so that the projects can continue beyond their end. We need to have better coordination to involve all the stakeholders so that we can have results enabling us to have early detection and efficient action. That's why we are always struggling in this regard. And it was recommended that the country has an action plan which addresses priority health challenges in the plan of action, which will be budgeted and put different partners in form of networking so that it can be worked on and strengthen capacity, build capacity of the actors at all levels. Now, with that, thank you very much for your kind attention. You have the floor. I give back the floor to you, Chair.
Wow. Thank you very much for that very comprehensive presentation. And what a great way to surge into our last conversation where we will have Dr. Giorgio Pento sharing Uganda's experience before we have our community health workers share their on-ground experience. Dr. Pento, this is the time, please.
Thank you very much, Dr. Diana. I am sorry I can't zoom into your camera, and so you will not be able to see how this beautiful face of a Ugandan looks like. But my regards to all who is on this call, and it's my pleasure to be part of the team that is going to discuss this important subject of surging frontline health workers for pandemic preparedness and response. I will give you our current planning for community health system strengthening. Dr. Opento George Dugum is my name. Next slide. Next slide, please. Should I be the one to share? Yes, leave me there. I will take you through the background of my presentation, which I say will build around the CHW systems. And the CHW systems in Uganda, as we know, is anchored in the community health department and is operationalized in a number of other strategies and programs, as we shall see, including departments, and such departments include health promotion, education and strategic communication, health information division, among others. And on record, we have close to 150,000 community health workers. And these are commonly referred to as the village health teams. And the implementation of these CHW systems is basically by Ministry of Health of the Republic of Uganda, but of course with support from implementing partners. The vision for this CWH system is that we are looking at building a strong, sustainable health systems at the community level that provides access to quality health care for all. But we are here blessed with initiative of the PAC, and the PAC support to us has been through AMREF, and with that we have been able to train up to 950 village health teams. We have provided them with PPEs, that is personal protective equipments, and to these village health teams, we have given them a stipend of $20 US, but we have focused our attention to only eight high-risk districts in the northern part of Uganda and the West Nile regions of Uganda. Of course, we'll also know that the PAC initiative has supported for us the village health teams, and this village health PAC was aligned. The village health team was aligned to the rollout of the National Community Engagement Strategy for COVID-19, and basically underscoring the support to home-based care. And that's where we are treating, many of our patients who are negative, no asymptomatic for COVID-19. Next slide. I want to take you through the objectives of our CHW systems, which basically cannot be complete without making a mention of digitization of these community health workers' activities. And as you may know, the Ministry of Health is poised to actually scale up the use of digital tools and data within the community health programs. And currently we have several models with different partners, and these partners include BRAC, Living Goods, and Last Miles. But as you will know, the working on these different models is to ensure that they are all synchronized to one platform. We have quite a number of strategies and milestones, which include the community health strategy, the community health roadmap, and the community health information systems, which are all in development to ensure alignment and fast-track digitization of the CHW's activities, ensuring that they are adequately equipped and supervised, among others. Another key objective here is to build on the COVID momentum, which we have harnessed right now, and scale up the community health systems, strengthening for future epidemics and this future epidemic management, which we want to make sure that is not another reinvention of the wheel if a new epidemic occurs, but we also want to make sure that we have improved health outcomes and aligning the African Union commitments to recruit, train, and deploy 2 million community health workers across the country. One key important objective here is that we need to have a harmonized digital tool, and this harmonized digital tool we want to take into consideration of the low technology alternatives, especially for areas with limited network coverage, which is usually a problem in this country. Next slide. Yes, we have learned lessons in trying to implement our CHW systems, and this to us has created some opportunities as well. But lesson number one we have learned is that the community health information system is important and key to ensure alignment of the different CHW activities, including the digital health. And we have realized that digitization provides real-time data and timely response. And so digitization of training helps reach large numbers of village health teams in a very short time. And this we have observed during this time of COVID pandemic with several episodes of lockdown. And so this digitization has come handy. Now, digitization of training has helped carry out effective training at a time when face-to-face training was very difficult due to this COVID-19 lockdown restrictions. aimed at reducing spread of the disease. It is key to scale up community health systems, strengthening for future epidemics management and improved health outcomes. It is also key, this is a lesson we have also learned, that it is also key to have the village health teams registered in the CHW registry to track the CHW activities. And this, we are gearing it up to be a thing of a daily use. Next slide. Next slide. Yes, please. Let me take you through a few challenges which has hampered our progress. One of these is poor telecom connectivity in hard-to-reach areas, and this is normal, but it has been a proven challenge. Also, the VHTs are not very tech-savvy, as you may know, and does need more orientation so that they become, compliant with the new technology we are trying to apply to them. The cost of digital delivery on the MHO and partner side, coupled by direct cost to the village health team, like the mobile devices and airtime, are really a high cost, very huge cost. But there are also lack of harmonized incentives. This incentive strategy to community health workers is affecting the motivation and the work of these community health workers. And also another challenge is that the VHTs are all not registered on our community health workers registry. And so it is very difficult to track them if you need urgent information around them. So to say also there are quite a number of tools, and these divergent tools among community health workers are actually being promoted by the different partners. Every different partner come with different tools because their interest in covering the indicators they want are also divergent. And so you get to have so many tools being deployed by the same community health workers. Attrition rate for these community health workers is high, but these are due to a number of reasons. Next slide. Next slide, please. Yes, but even when the challenges and lessons are numerous, we have quite a limited amount of recommendations we have come around with, and I want to share this with you. One is streamlining of digital interventions, and we know this helps to avoid duplication and also identify high priority areas. This is our recommendation number one. Recommendation number two is support in subsidizing access to digital facilities for the VHTs. And we know this will help to deploy quite a lot of these tools to our communities. Three is to develop a country roadmap to standardize and scale the integration of digital tools within community health, standardizing the use and functionalities of these digital tools while strengthening data use and reporting. The fourth one is fast track the development of community health strategy, which currently we are writing with the use of a consultant. And we think it will help us put all these recommendations in line and in perspective. There is need to support the village health teams to be registered in the community health workers registry for easy tracking. And it's a very important recommendation. And with our support, with support from our partners, I think we shall go miles. We are also recommending innovations for utilizing low technology digital interventions for areas particularly limited with network coverage. And finally, we want to enhance advocacy and political mobilization to ensure prioritization of community health by member countries. In essence, make community health a political choice. Next slide. Next slide. is to thank you and say good deliberations. Over to you, Dr. Diana, as you moderate.
Wow, thank you so much, Dr. Opentho, for such a very enlightening presentation. And colleagues, excellencies that could have joined us in the middle of this conversation. You found when we had gotten remarks from Dr. Nkenga Song, but also Her Excellency Salif, who really spoke broadly around the role of community health in not only advancing health, but also advancing the development agenda. We also had the opportunity to hear from Dr. Herolinda, who spoke about the PACT initiative and how they've been able to deploy 17,000 community health workers. We had the opportunity to listen to 3 country experiences: Egypt, that spoke about the community health worker integration; Cameroon, that highlighted the amazing work about their integration; and now Uganda, speaking about the digitization efforts and how far they have come. But we're also aware that communities and countries are ultimately the world, are only as strong as their community health system. And very well aware that at the community level, the people that advance this work are community health workers. And so without further ado, allow me to welcome our community health workers that are going to share their experience in the countries where they've been operating. And for this conversation today, we're privileged to have a community health worker from Cameroon, Mr. Ngambi Ibrahim Sherif, who is a community health officer of the Nkondong Health District in the Central Region, and he's speaking on behalf of the CHWs in Cameroon. He holds a master's in public health and has really progressed through the professional development journey as a community health worker. Our second and last community health worker is Rita Nakakande, a community health worker supported by the Ministry of Health. She has served as a community health worker for the last 5 years and has served 400 households. Rita has a daily work plan where at least she visits 3 households and also does community events in more than 10 households. Without further ado, allow me to welcome Mr. Ngambi Ibrahim Sherif, who will speak about the community health program in Cameroon. Mr. Ngambi, this is the time.
Ok, merci de m'avoir passé la parole.
Thank you for having given me the floor.
Hello.
Hello.
Yes, we hear you.
Ah, ok, d'accord. Merci de m'avoir passé la parole.
Thank you for having given me the floor.
On va commencer. En fait, le plan.
We are going to start.
A été détaillé comme suivant.
The work, the opportunities, the work, everything that we have done has been presented. The recommendations and the problem. So before the pandemic, the activity was quite calm. We did not have a lot of things to do. We are helping the district health officials in their different activities, especially with the focal points of surveillance. And with time, things changed with the arrival of this pandemic. So in fact, our community was affected because the last the people did not want to want us to work with them, so we were not able to have. We got support from Africa CDC, from Red Cross, and from the World Health Organization. So training continues in matters of protection and deployment according to the different levels of intervention, which allowed us to do actions which were fruitful, like community sittings, training of personnel in some hot spots from door to door and in the places where we had been deployed. And this one brought visible change within our respective communities. As challenges and opportunities that were presented, the major challenge that we had was communication for change of behavior, because the population had badly integrated the pandemic, and the people did not even want to be vaccinated. So the opportunities helping the district officials for doing their activities and local collectivities that we're working with in everything that we had to do. As a recommendation, everything that we can say as it is supporting these people, village health communities during the pandemic, and community interventions related to them, giving us enough means to work and to allow us to communicate in favor of vaccination. This one maintaining and training people with the working with the traditional leaders, the religious leaders, and other local leaders, the possibility of going to the whole communities from door to door, sensitizing the population. That is the presentation that they allowed me to share with you. I thank you for your kind attention.
Thank you so much, Mr. Shali, for sharing that experience from the community health workers in Cameroon. I'd like now to welcome Madame Rita Nakakande to share over the 8 minutes around the high experience as a community health worker in Uganda. Rita, you're welcome.
Oh, thanks so much, Madam. My name is Rita Nakakande. I'm a Ugandan and I'm a community health worker. I've done this work for more than now 5 years. Now I'm coming to 7 years doing this work. I work with the Ministry of Health with support from Living Goods. I was trained, and after the training, I went out to the field, and the first thing which I did is to register the families I have in my community. Right now, I have over 500 families registered in my smartphone, whereby all the work I do is in the smartphone. My work is to assess, treat, refer, and then follow up, especially in the most deadly diseases like malaria, diarrhea, and pneumonia. Then we also advise the pregnant mothers to go for antenatals. We advise them to take the first steps to healthy pregnancy. For example, to go for antenatals, advise them to feed, to get good nutrition. We advise them to get protected. We also strongly advise them to deliver from the health centers. We also advise these women to take their children for immunization. Remember, immunization is so important. So we advise them that please should take your children for what? For immunization. We also advise these women to go for family planning. It's our responsibilities as community health workers to teach these women that they should go for family planning. as we community health workers, we are able to give them the short terms, and for example, the long terms, we refer them at the health centers. And we have not forgotten about the COVID-19, which is going on. It is still our responsibilities as community health workers to create awareness in our communities, just because these communities have confidence in us. So we always go there, teach them about COVID-19, how it is spread, how it is prevented. Is all our work as community health workers. And we really appreciate that during this period of COVID-19, we have not been left out. Living Goods and the Ministry of Health has supported us so much in the PPEs. So we got to the field when we are really confident that we are going to be safe as we community health workers. And even the communities, we advise them that please, you should put on masks. You should wash hands with soap and clean water. We also advise them not to go in clouds, not to gather in very big clouds. So it's our responsibilities. And we appreciate the government or the Ministry of Health and Living Goods because they have supported us so much. If it wasn't so, we would be able to go through this pandemic which is going on. So that's how I do my work, or that's how community health workers do their work. We assess, treat, refer, and then follow up. But we appreciate that we also have this digital smartphone, whereby all our work is done on a smartphone. For example, I told you that I registered all my families I work on my phone. So when I got the family, for example, by the time before COVID came, I could move in the community. But right now, we are being limited because of the COVID-19. So we gave them our numbers. They can also call us, and we help them. When they call, they come to our homes, make sure that we observe the SPOs so that we can be safe and even our clients to be safe. So that's how we do our work in our communities. Thank you so much.
Wow. Thank you so much, Rita, for sharing that amazing experience of your work together with the Ministry of Health in Uganda. Your Excellency, all distinguished guests, our panelists, we're left with about 6 minutes for this session before I hand over to Dr. Mohammed, who has been such a strong pillar in moving this work forward. But before I do that, we've received a number of questions from our participants that we might not be able to answer all, but just wanted to flag 3 important questions. One is a question for Dr. Herelinda and the Cameroon team, that we see a number of difficulties in the integration process of the community health worker program. And the question is that how do you recommend, Dr. Herelinda, that countries go about with the integration? The second question is for Egypt, Dr. Remy. A question has been asked on how is it easy for community health workers to monitor the 3,387 contacts that you alluded to. And the last question is for Uganda, is for Dr. Upento. There's a question around what is the status of the offline digital tools for moving this work forward. I want to request we start with Dr. Herelinda to answer the question, and then Dr. Remy will follow. Cameron will follow, and lastly, Dr. Opento will respond, and then I'll hand over to Dr. Mohammed. In that order, please, Dr. Herelinda.
So thank you so much, Diana. So I think the issue of integration, there is not a single response that will be fit to all the countries. So my recommendation will be, it's better for the countries to assess their own situations understand the resources and the stakeholders whom they already have in their countries. Then based on the country context, they can come up with some best ways for them to integrate the CHW activities within their national health system. So I don't have a response that will be fit to all the countries, but that is just a recommendation.
Thanks very much, Dr. Herelinda. Dr. Remy, on the question around how you're able to monitor the 3,387 contacts. And as Dr. Remy is planning to chime in, Dr. Opentho, are you able, please help respond to the question around the status of the offline digital tools?
Yeah, thank you very much, Dr. Diana. And thanks for this question and probably an innovation for us to make sure that we go around the issue of digital tools which are actually offline. And you know, we are saying that there are areas with low connectivity, and this is in hard-to-reach places in the country. But also we are saying that a number of models by different partners in the offing. We made mention of drug, living goods, last miles. We did not mention one coming from Medical Team International and UNHCR that is also trying to pilot what we call the smart paper technology. And that smart paper technology is basically an offline digital tool where you take a picture of a piece of paper where you have recorded your information. And in no time, you can send that picture and gets onto our DHI store through the HMIS. And that is some of the things we are trying to employ. And there are quite a number of other local innovations that uses offline digital tools. We are saying they are still all in their infant stages being worked upon, but we are saying they should work on them to ensure that they are all synchronized. We want to have one digital platform under the community health department that can bring on all this, whether offline digital tool, whether online digital tool, they will be together on the same platform, which we are now trying to strengthen. With the division of health information, I think it will not take us long before we have all this synchronized, both the online and the offline, but they are all on the development processes. Thank you very much. Over to you.
Thank you very much, Dr. George Opentho. And the last question that has been asked for Cameroon is around how they've been able to integrate all these efforts in one space. And so, Dr. Chancelin, please help respond to that question before we end this webinar.
Thank you, Dr. Diana. Ce qu'il faut dire, c'est que les communautaires font déjà partie.
The community health officials are part of the health system. So each district has got these community health agents. And now in matters of the answer to COVID particularly, these community health officials used the tools that can help them such that data is collected and directly taken to other, integrated into the database, which had the indicators of surveillance, let it be contact follow-up or suspected cases or others, including the tools on the number of households visited and surfaced. That is to say that those community health officials are integrated in the health system. Now in Cameroon, we have got surveillance which is based on indicators and events, including this type of surveillance mainly. Now, the challenge is to have these community health agents to get some kind of status, because there is no status that allows us to regularize them.
ليس هنالك موائمة في هذه الأمور.
Interference, I've got interference from Arabic.
Merci pour la question. J'espère que j'ai répondu.
Thank you for the question. I think that I've answered your question very well. Diana?
Thank you so much, Dr. Chancelin. It's been an amazing 1.5 hours hearing the experiences of the countries, hearing the experiences of our amazing community health workers. And I know that Dr. Heralinda has informed me that Dr. Mohammed has hoped off for another meeting, but I just want to really heartily thank President Salif, Dr. Kenga Song, Dr. Mohammed, who have offered the time to join us for this conversation. I also want to thank our panelists from Cameroon, Egypt, Uganda. What an amazing source of experience and inspiration that you shared for us this afternoon. In a very special way, I really want to thank the community health workers that continue to provide services at the last mile for the communities. A huge shout out for you, Rita and Shay, for joining in and sharing both the Uganda and the Cameroon experience. I'd also love to thank the team, the participants joined and have really been a part of this amazing experience. I know there are many questions that have been shared. I want to encourage us that tomorrow, same time at 2:00, we'll have a follow-up conversation. I want to request that you please plug in. There'll be a debrief at the beginning where perhaps some of these questions will have answers, but also amazing conversations will happen. And lastly, the Africa CDC that has been at the forefront in leading this effort, dear partners, Financing Alliance for Health, Last Mile Health and Living Goods. Thank you for all the support in making this webinar very successful. Thank you very much and have a great rest of the day. Bye, everyone.
Thank you very much.
Bye-bye. Thank you.
Doctor. Thank you so much,
Bye.
Doctor.
Thank you. Thank you. Thank you.
Thank you. Bye-bye.
Bye-bye. Au revoir. C'est mieux.
So I believe it's only the organizing team that is still online. And if that is the case, then we can start our meeting. Hey, we still have a lot of participants. Oh, wow.
Yes,
so
we have
can
about
I
2
kindly request the participants to leave the meeting? And we request them to join again tomorrow at 2 p.m. using the same link.
Dr. Herlinda, also I can share my Zoom link if easier for us to have the debrief session. Thank you.
So what do others think? Should we join using another link? Because I can see we still have a number of participants online. They are dropping though. So is it Paco or Tade who is going to share the link so that we can join as the organizing team?
Yeah, I can share it on
Okay.
via our other channel.
Okay, please do so. Okay, thank you. And we should now stop recording. The meeting is over for today.
Recording stopped.